السلام عليكم ورحمة الله وبركاته. أنا دكتورة صفاء إبراهيم خضر، مدرس الطفيليات الطبية، وإن شاء الله النهاردة هنتكلم على الفيلاريال نيماتودز سبيشالي الفيتشريريا بانكرافتي والبروجيا مالي، المحاضرة الخامسة في موديول 18. As we have known before, nematodes are divided into phasmidia and aphasmidia. Filarial nematodes belong to the phasmidia. They live in the tissues or body cavities of vertebrate hosts. They are viviparous. This means they lay their microfilari in blood, lymphatics, or tissues of their hosts. They need an arthropod vector to complete their life cycle. According to the habitat, filarial nematodes can be divided into either adults living in lymphatics, as the Filarial Nematodes and Brugia malay that will be discussed today inshallah, or adults living in subcutaneous tissues as Onchocerca volvulus and Loa Loa. Regarding Filarial Nematodes, it causes what's known as elephantiasis, which is an ancient disease that has been known since pharaohs. Pharaoh Mentuhotep II, who ruled Egypt 4,000 years ago, had the disease. Additionally, it was known to cause a curse that is named as San Tomasco curse. Filarial Nematodes was named according to its discoverers, Butcher and the two bankrupts, the father and the son. It is a disfiguring disease that leads to long-term disability in 30% of the affected cases. It approximately affects about 120 million people all over the world. In the year 2000, the WHO established the global program to eliminate lymphatic filariasis, which has the goal of eliminating lymphatic filariasis as a public health problem by the year 2020. Adults live in the major lymphatic vessels, ducts, and lymph nodes of the humans, being tightly coiled into nodular masses. They are found in the afferent lymphatics of the lower half of the body, either lower limbs or genital organs. Geographically, it's endemic in warm countries, especially in tropics and subtropics, surrounding or ranging from 30 north to 30 south surrounding the equator. In Egypt, it's present in Qalyubiyya, Daqahliya, Sharqiyya, with foci in Cairo, Giza, and Asyut. Adults are thread-like, and this is why they are named are filarial nematodes. They have smooth cuticle and bluntly rounded ends. Male is about 4 centimeters in length, and female is about 6 centimeters in length. Additionally, female is stouter. Females are viviparous, producing thousands of microfilari. The microfilaria of Filarial Nematodes is characterized by being about 200 to 300 microns in length. They possess a pointed tail. Its tail end is free of nuclei. It possesses a loose sheath and it runs in a smooth, graceful curve. The female, which is viviparous, lay the microfilari into the lymphatic through the thoracic duct. These microfilari go to the peripheral circulation, and microfilari in peripheral circulation exhibit what's known as periodicity. Periodicity is the appearance of microfilari in the peripheral blood at a certain time of the day. This means at other times of the day, microfilari disappear from the peripheral circulation to be present in the pulmonary blood vessels. Microfilaria of Filarial Nematodes have a nocturnal periodicity, so the maximum number of microfilari can be found in the peripheral circulation only between 10 p.m. and 2 a.m. Many explanations for periodicity have been suggested. One of them is being a sort of adaptation between the parasite and the intermediate host, so microfilaria have to be present in the peripheral blood at night when its vector bites. During the day, microfilaria are concentrated in the blood vessels of the deep tissues, predominantly in the pulmonary vessels proximal to the pulmonary arterioles. Microfilaria die within few months unless they are sucked by the appropriate intermediate host. The life cycle of Filariae runs in two hosts. The first is the definitive host, or man, and the second is the intermediate host, mosquito. And as we have studied before, we have known that female mosquitoes are the only who bite, which bite, but male mosquitoes do not bite. Because of the nocturnal periodicity, night-feeding mosquitoes are the primary vectors of Wuchereria. In Egypt, it is mainly female Culex pipiens. In the Pacific region, some strains of Wuchereria have a diurnal periodicity, which is named as Wuchereria bancrofti variety pacifica, where daytime feeding mosquitoes are the major vectors of this strain, especially Aedes aegypti. These are photos for Aedes and the Culex, the vectors. Inside the vector, when the microfilariae are ingested by the anthropophilic mosquito, and by the word anthropophilic we mean mosquitoes that prefer to bite humans, inside the vector, the microfilariae are taken or are ingested with the blood meal, where microfilariae lose their sheath within 2 to 6 hours inside the stomach of the insect. Following that, they penetrate the gut wall by their oral hooks to reach the mosquito's thoracic muscles. In the thoracic muscles, they molt for the first time to become short sausage-shaped larvae. And within 2 weeks, the second molt to be elongate cylinder larvae or third stage filariform larvae will occur. This third stage filariform larva, which is the infective stage, is about 2 millimeters in length. Then they migrate through the hemocoel cavity to reach the proboscis or the mouth part of the mosquito. So at this time, when the mosquito feeds on another host, it will infect him by the third stage filariform larva. So inside the vector, it is a cyclo-developmental transmission. This means there is no multiplication in the number of the larvae inside the insect. When the mosquito feeds on the suitable definitive host man, it pushes its proboscis inside the skin, as we see here in this photo, but the labium doesn't enter the skin. The warmth of the skin attracts the infective larvae, which pierce the labium of the mosquito at the Dutton's membrane and drop on the skin. The infective larvae, which are again the third stage filariform larvae, enter the skin by their own activity through the wound made by the mosquito's bite or through any other abrasion performed in this skin. After entering through the skin, larvae migrate through the peripheral lymphatics to settle in the larger lymph vessels, where they become adult worms. Inside the human body, as we see here, pathogenesis can be either due to living or dead adults. So the main pathogenic the stages of Wuchereria are the living and dead adults with their toxins, and the juvenile adults or the growing larvae, as they provoke inflammatory and immunological reactions in the lymph vessels and lymph nodes. Regarding living microfilariae, they elicit no response at all. The presence of living worms initiates a reaction in the affected lymph vessels and lymph nodes, which leads to infiltration with plasma cells, eosinophils, and macrophages around the worms in the lumen of the vessels. This is accompanied by proliferation of endothelial and connective tissue, leading to the tortuosity of lymph vessels with oozing of serous fluid. When adult worms are alive, the lymph vessels remain partially patent, although their walls are damaged. The endotoxin of Wuchereria enhances the inflammatory reaction. Death of worms causes progressive fibrosis and obliteration of these blood vessels, of these lymph vessels by the granuloma and thrombi formed. The increased permeability of the lymphatic vessel wall leads to leakage of lymphatic fluid with high protein content in the surrounding tissues, resulting in the characteristic hard, non-pitting, brawny edema characteristic for elephantiasis. Fibroblasts migrate to the edematous area, generating thickening of the subcutaneous tissues, giving the classical picture of huge enlargement or elephantiasis of the affected area. Clinically, the disease is divided into 3 stages: the incubation period, the acute inflammatory stage, and the chronic obstructive complicated stage. Regarding incubation period, it is the time between the entry of the third stage filariform infective larvae into the skin and the appearance of the microfilaria in the blood. It lasts about 1 year or a little bit more. There may be transient lymphatic inflammation with mild fever and malaise. There is intense lymphatic inflammation in the lower half of the body with frequent recurrence of acute febrile episodes called elephantoid fever. Episodic attacks of sudden onset of fever, painful lymphadenopathy, lymphangitis, rigors, and sweating are the manifestation. Attacks last for a few days and often recur at frequent intervals for months or even years. The affected lymph vessels are swollen, painful, with reddened, overlaid skin, which known as lymphangitis. Common signs include inguinal lymphadenitis, orchitis, hydrocele epididymitis, or even temporary edema of the affected limbs. This is a photo showing acute adenolymphangitis stage, or ADL. About the chronic obstructive stage, or the stage of complication, number one and the most common is the elephantiasis, which is the enlargement of one or more limbs, scrotum, breasts, or vulva due to the increased permeability of the walls of the obstructed lymph vessels, leading to leakage of lymph-rich in protein under the skin, causing cellular proliferation of this connective tissue with fibrous tissue deposition. The skin and the underlying tissue are hard, dense, and pit only slightly what's known as hard or brawny edema. These are photos of elephantiasis. These are the stages of elephantiasis. Another complication is the lymphoscrotum or lymphatic varices of the scrotum, chylocele or rupture that occurs due to rupture of lymph vessels into the tunica vaginalis, chyluria due to the rupture of obstructed intra-abdominal lymph vessels into the urinary passages, chylous ascites and chylothorax due to the rupture of obstructed lymph vessels into the peritoneal or the pleural cavities, chylous diarrhea due to the rupture of lymph vessels around the intestine. And this is a photo that compares between the normal urine and the chyluria. As we see here, it is milky in appearance. How to diagnose filariasis? To diagnose Wuchereria bankirofti, direct methods, immunological methods can be used. Direct methods, we can see either microfilari or adults. Microfilari can be detected either in blood or even in the chylous urine. To obtain a proper sample for microfilaria of any filarial nematodes, generally, or of Wuchereria bankirofti especially, microfilari begin only to appear after 1 year of infection. They are rarely found when lymphatics become obstructed. Blood must be collected at the proper time. This means when the greatest number of microfilari are present in the peripheral blood, or what's referred to as periodicity. For Wuchereria with nocturnal periodicity, blood should be collected between 10 p.m. to 2 a.m. But for Wuchereria with diurnal periodicity, blood should be collected at about 4 p.m. Microfilari are more to be found in the capillary than the venous blood, and more to be found in the ear lobe than from finger. To diagnose microfilari in the blood, we can obtain fresh blood to search for or to see microscopically the movement of the microfilari. We can additionally take a thin blood film or a thick blood film. By thin smear, we means that blood films will be fixed with methyl alcohol and stained with Giemsa, like this. But by thick smear, more amount of blood will be taken from the patient, about 20 microliters of capillary blood, from which it's allowed to dry, then stained with Giemsa. And of course, thick film is more accurate because, or it can yield more amount of blood because we obtain more amount. For detection of microfilaria in blood, the techniques used can be either obtaining fresh blood to search for the movement of microfilaria, or thin stained smears or thick stain smears. By thin stain smears, we take a drop of blood and we put it on a slide, then we make the blood film and then fix it with alcohol, methyl alcohol, and stain it with Giemsa. In thick stain smears, we take more amount of blood, about 20 microliters of capillary blood, and then allow it to dry and then stain it with Giemsa. Of course, it's more sensitive because here we obtain more amount of blood. This is the shape of microfilaria in blood, of Vitelliria bancrofti in blood. A fourth method for detection of microfilaria in blood is knot technique, and it's used when it is scanty in the peripheral blood. Additionally, polycarbonate filter can be used for the same purpose. Another method is quantitative Buffy coat technique. Additionally, microfilaria can be seen in the chylous urine or in the fluids aspirated from hydrocele or chylocele and so. And additionally, adults can be seen in biopsies taken from affected lymph nodes, ultrasonography, or even X-rays can show calcified adults. Regarding immunological diagnosis, serodiagnosis is of value only in late chronic infections when microfilaria are absent from the peripheral blood. Many tests can be used, example indirect fluorescent antibody technique, ELISA, or even immunodiagnostic strip test, in which antigen detection is examined instead of antibody detection. This is the shape of immunodiagnostic strip test. If we perform a blood picture for a patient with Vitelliria, usually we find moderate eosinophilia. How to treat a patient with Vitelliria bancrofti? If the patient is still early in the acute stage, we can give him medical treatment. The most famous one is hitrazan or diethylcarbamazine, or even ivermectin that is lethal to microfilaria, and if it is repeated, it can even kill adult worms. But if the case is complicated or late, at this time we revert to the removal of elephantoid tissue by surgery. Regarding Brugia malayi, adult here inhabit the lymphatics of the lower limb below the knees and the lymphatics below the elbow. Microfilaria here has nocturnal periodicity, so they are sheathed. They are shorter than those of Vitelliria bancrofti, being about 175 micrometers, and their tail possesses about 2 terminal nuclei, and they run in stiff curves or kinky curves. The life cycle of Brugia malayi is just like that of Vitelliria, but there is more than definitive hosts, not only humans, but additionally reservoir hosts as cats and monkeys are present, and the vector here is genus Mansonia instead of Culex and Aedes in Vitelliria bancrofti. The pathogenesis and clinical picture of Brugia is similar to those seen in bancroftian infections, except that elephantiasis affects primarily the legs below the knee, the arms below the elbow. They are less severe than bancroftian filariasis, and genital involvement usually and chyluria here are rare. What about tropical pulmonary eosinophilia or occult filariasis? It is a syndrome that's caused by both Vitelliria and Brugia, in which there is diffuse pulmonary infiltration, which may progress to chronic interstitial fibrosis with significant local and peripheral eosinophilia. It is allergic in nature and related to trapping of microfilaria in the pulmonary blood vessels. So the patient will present with fever and asthma-like symptoms, cough, dyspnea, wheezes, lymphadenopathy, and eosinophilia also are present. Diagnosis of such cases depends on clinical picture, X-ray, which shows diffuse interstitial infiltrates and the rapid response to DAC. However, no microfilaria can be detected, as we have mentioned. It is a type of occult filariasis. Regarding the differences between Vitelliria and Brugia, Vitelliria is present between 30 north and 30 south but Brugia in the Malayan Peninsula. Habitat of Vechereria habitat of Vechereria is in the lymph nodes and vessels of the lower limb and genitalia. Here in Brugia it is distal to elbows and to knees. Microfilari of both are sheathed and both are nocturnal, but here tail end is free of nuclei and here with 2 nuclei. Here it is smooth, graceful, and here it is stiff. The vector here is Culex, mosquito, and Aedes in variety Pacifica, but the vector here is the female Mansonia. The reservoir host here is absent, but here they are monkeys. There are monkeys and cats. Clinical picture here, of course, is more severe, and genital involvement in Brugia is rare, and tropical pulmonary eosinophilia can occur in both. How to prevent and control Vechereria? Number 1, mosquito control can be achieved by spraying residual insecticides, environmental sanitation regarding the elimination of the breeding places of mosquitoes, the use of insect repellents to avoid mosquito bites in an endemic area, mass treatment with DEC to destroy the microfilaria, additionally the use of bed nets. Note to tell that in 2015, Campbell and Omura were awarded Nobel Prize for Physiology and Medicine for discovering ivermectin that decreases the occurrence of lymphatic filariasis. Thank you.